Good morning. Welcome to day 2 of the third FORC and the first in-person FORC. It's my great pleasure to briefly introduce someone whom I could spend, an hour describing with glory. Isaac or Zach Kohane is the Marion B. Nelson Professor of Biomedical Informatics at Harvard Medical School, where he is also the inaugural chair of the Department of Biomedical Informatics. He's also Associate Professor of Medicine at Brigham and Women's Hospital. And in a nutshell, Zach is a truly visionary scientist, translating into practice the promise of data in curing and diagnosing diseases and in the delivery of care. And I did pull one sentence from his website that I want to share with you. Kohane is always on the lookout for like-minded quants who share the same goals to bring a better future for medicine and biomedical science to the present. And that's where you come in.
That is absolutely right. Thank you. Wonderful introduction. Is anybody watching the chat? Could you see, can they hear me?
Yeah.
All right, excellent. So it's my pleasure today to talk to you about the use and abuse of group labels. So I've already failed the first group label because I thought I had 20 minutes, and it seems like you generously gave me an hour. So this will allow me to do two things, hopefully well. One, which is to speak more slowly than I usually do, which will be to everybody's benefit. And the second is to allow you to interrupt me at any point with questions. Fair? So I'm counting on my colleague here who is looking at the chat to, if someone wants to interrupt with a question, just let them interrupt. If any of you here wish to interrupt, please do. When does this officially end? What time? 10:15. Perfect. Okay. So this is a very, very important discussion, and one that I think is easy to go awry. And that's why I want to have a lot of questions asked. Because as you'll see, the thesis I'm going to make is that the use of these labels like African American, Black, Jewish, gay are labels that certainly have strong social construct components, and sometimes are used in ways that are incredibly noxious and harmful, but can also be used in ways that are very helpful. So it's a very tricky thing where you have such a loaded label, where sometimes the very same parties who abhor the use of that label in one instance actually are promoting it in the other. And I think that's going to be the crux of the discussion that we're going to have today. I should also note that in this department that I have the privilege of having founded and leading now with about 15 faculty, we do a lot of different applications of machine learning, all the way from genomics, all the way to clinical care. And even though my main focus is in machine learning these days, I'm actually not going to be talking very much about machine learning today. And that's because the same issues apply. Well, it depends what your definition is of machine learning. If your definition of machine learning includes, for example, any model that gets informed by the data to allow prediction and classification, let's say logistic regression, then we're talking about machine learning. But if you machine learning, it has to be that it's some form of deep learning, some that only self-teaching systems like AlphaZero is what constitutes machine learning, then I'm not going to be talking very much about machine learning. But in either case, the use of these labels is highly pertinent. So let's start with one of them. There are many, many examples to draw from noxious use of labels, but there was one that comes to mind that happened quite recently, which is in the National Football League, it was found that several players were being denied compensation and recognition of the damage that traumatic brain injury of football was causing because they were African American, and having that label allowed somebody in the organization to say, well, they're starting from a lower cognitive starting point. And since they're starting from a lower cognitive start point, whatever their end point is, we're expecting it to be lower. And so if there's lower cognitive performance in the middle or at the end of your football career, maybe it's not all attributable to football, but it's attributable to the fact that you're African American. There's multiple layers of badness here. Starts with flawed studies, flawed epidemiology, but then it gets established as policy. And what's amazing to me is how long it was able to be policy before someone uncovered it. How could this not be the case? And I think very few people, I'm hoping nobody in this room or online, would argue that this is a particularly egregious case of the use of labels, group labels, in a frankly racist way. Things that are not always that simple. There was this headline that was repeated in many, many locations around in the 2020 that certain lab tests provide one result if the patient is Black, another if they're white. The debate over race adjustments is heating up. This created a huge controversy. And in the end, it ended up being a very productive controversy, where as a society, I think we've moved forward. But in order to explain how that is, we need to get back to some fundamentals. I wrote a paper in, when was it? 2007, maybe? 2009. And I called it The Twin Questions of Personalized Medicine. Who are you and who do you most resemble? And I said personalized medicine because that was the kind of language that was being used then to describe giving care that is most appropriate for you. But it could also be called precision medicine, or frankly, just regular medicine. And what do I mean by that? Let me ask the question. Let's try to get, what is a diagnosis? Anybody want to venture? What is a diagnosis? Believe me, you don't have to go to medical school to know the answer to this. Believe me, you can go to medical school and not know the answer to this.
Bucketing of symptoms into categories.
That's good. I like that one. Anybody want to take another? That's a pretty good one. But just because you're a fancy professor doesn't mean you have only the right answers. Yeah.
A prediction that you have some condition.
All right. Good. So I will say the most general version of this is, what is diagnosis? It has two parts. First, what can I say? I'm just looking at you. What can I say about you? I can measure your blood pressure. I can measure a genome. And I've had friends of mine, computer science professor like Matt Mike, who had a child who had a disease, and he had a mutation in a gene called NGLY1. And his child became the first ever human being diagnosed with a disease because they had a mutation in this gene NGLY1. So whether I'm taking your blood pressure and I get a reading, or I do a sequencing on your genome, I'm finding out things about you. So that's who you are. But to make a diagnosis, that's not enough. I need to know, how do you compare to other human beings? So to go in the direction that our esteemed professor sent us, what group of individuals do you most resemble? Because in the end, the best doctor, and I mean the best doctor, is simply doing a version of the following. Here's what you look like. This is your blood pressure. And if I put you in a group of human beings, full diversity of human beings, this is what are the other characteristics I can expect to see. And I can say, oh, you have high blood pressure and you're a young man. Well, I'm expecting to see one of the following sets of things in you, like potentially a kidney problem, potentially a family history, various measurements that I haven't made yet on you yet, but I know that they're likely to be true of you because you're a member of that group. So diagnosis is really an act of group membership assignment. That's what diagnosis is. The next step is to say, well, can I define that group accurately enough so I can tell you, where our colleague here said, where you're going to go? Are you going to be the group of individuals with hypertension who are going to, because of the disease, rapidly develop kidney disease? Or are you a group who are going to be fine until your 60s or 70s, where you might have a higher risk of heart disease? So can I more tightly define which subgroup you belong to? And then, best of all, can I define which subgroup you belong to with expectations of trajectory that maximizing across all those possible trajectories will give you the best possible treatment? That's it. That's what we want from our best doctors. Given an observation of who you are you most like? And so we're assigning you to a group of individuals with your background, dietary background, ethnic background, exercise style background, medications you're on, environmental exposures, stress levels in horrible school you're going to, and all those combine to create a multi-axial group. And so I had the pleasure of being on the National Academy of Science committee that was tasked to define precision medicine. And we came out with a report in 2011 describing it. And like all National Academy reports, even though you can pay for a book, you can just download it for free off the nap.edu site. And what we had at the time, we wrote this in 2010, 2011, we had acute envy of Google Maps. And why is that? Because Google had shown us how by layering on multiple data types onto a single set of coordinates, latitude and longitude, although each of these different annotations, measurements of these different data modalities had only modest value, together they created an incredibly invaluable ecosystem such that having knowledge of all the layering of human services, environmental exposures, where your friend is, have turned us all into amateur geographers with our smartphones. And we said, boy, wouldn't we want to have such a high value ecosystem that brings together all these data types in this fashion? So could we have, metabolomics, proteomics, RNA profiling, genomics, environmental exposures, and so on, all layered on top of the common coordinate system, this time not being longitude and latitude, but this time being individual humans, to get a sense of, from these multiple perspectives, what group does this individual really belong to? And people have misunderstood precision medicine. They thought we meant precise as in a lot of minute, able to measure minute differences, and they kept thinking genomics, that what we really meant was genomics. And in fact, this committee was meant to go beyond genomics. And what we're saying is we need to be able to look at human beings in a multi-axial way. That looking just at your genomics, or just looking at your zip code, or just looking at what you're eating, if you let them in and of themselves, which is what most medical studies do, doing something incredibly reductionistic. You're looking at a human being from just one perspective, their diet or their exercise. And obviously these things interact. So what we wanted to call for, and we did, is for a multi-axial view of human beings as being fully diverse. And when I say diverse, think of all possible spaces of human classification, and see where do you fit in that multi-axial classification, so that we can provide you the most accurate diagnosis, most accurate prognosis, and most accurate, the most helpful treatment. And I was really privileged when to be, I think a year after our report came out, to be at the White House when then President Obama announced the Precision Medicine Initiative, which then became the All of Us campaign, which said, let's actually try to do this where we measure mostly health measures out of healthcare systems, plus genomics, a bit of questionnaires. So I had to do this little detour in order to bring you back to what I told you before about the controversy that I told you about. Do medical algorithms have a race problem, and that certain lab tests provide one result if patient black, another if they're white? Okay, so how did this actually happen in the real world? What the real concern was a specific test. There are other tests, but this is the test that got the most attention. Something called the estimated glomerular filtration rate. So your kidneys filter toxins out of your blood. They reabsorb some things like sodium and glucose, and they dump out some other things like urea. And they also dump out something called creatinine, which is very useful because we want to measure GFR, because we want to measure kidney function. Why? Because it's really important to know what stage of kidney function you have, because if you're heading towards the bottom, first you want to try different medications and lifestyle changes to help improve kidney function. But then as you get to the bottom, you need to do things like dialysis, and if you're lucky, get a transplant to correct that. And so there's over 230 million tests given per year to measure creatinine in the blood or in the urine in order to, mostly in the blood, to measure how well the kidneys filter. And as it says here, this test is used to diagnose and stage chronic kidney disease, choose the dose of medications. Now, this is important because if you have cancer, God forbid, for many chemotherapeutic agents, you want to give the highest dose possible. That's going to kill the cancer and be as kind with the rest of you as possible. And knowing what that dose is going to determine by kidney function. If your kidney function is lower, then you want to give less of that drug. If on the other hand, if you give too little of that drug, maybe you're not hitting the cancer hard enough. So, estimating the glomerular filtration rate is really important. So it used to be that we had back in the 80s, we had an equation that was just one equation for all people. One equation for all people. It's not this equation I'm showing you. This equation happened in the 90s. So there was, in the 80s and before, there was an estimate of glomerular filtration rate that did not include a race label. And then some doctors, in order to adjust for the fact that if you look at the bell-shaped distributions of kidney function as measured by creatinine, African Americans are about 15% lower in their filtration rate than.
The actual filtration rate is lower, or there's just a way that the number you're measuring correlates to the growth.
This is the key issue. As measured, the best measurements that we can have that are ground truth in terms of the filtering function is 15% lower. But does that mean that, and filtering what? Filtering creatinine. But does that mean that actual function of the kidney is 15% lower? It is. That's the right answers. Who knows? Because we've only measured it in populations across just a few biochemicals. So hold that thought, because that's going to be incredibly important to the crux of the matter. So this correction factor was put in the 1990s, and it was done originally because, in fact, Black individuals have not had the greatest outcomes. But nonetheless, in somewhere between 2015 and 2020, a lot of people, and I want to point out, medical students in particular, started getting very uneasy with this equation because it seemed to potentially riff off of a monolithic label that could potentially be used in a racist way. It also seemed overly simplistic. And so medical students from multiple schools, I think it started at Harvard and then it spread to UCSF said, let's get rid of this correction factor. And let's go back to the one equation without the correction factor. Oh, by the way, it's really important that I point out this picture. That happy-looking person, the top right, is Professor Rajaban Rai. He used to be at Harvard College, a physics major. He's now one of our faculty and has done extensive work in this area. And wherever you see his face, this is a slide that I stole from him with his permission. I guess I didn't steal it, I borrowed from him. So that's what that means. And so,
Can I
please,
interrupt with something between a comment and a question?
sure.
So you're using the term Black as if it's a coherent, cohesive, medical, scientific thing. And I know that you know that here, what are we talking about? Self-identified Black? I mean, what is this thing and how does it make its way in? Many people here have heard Patricia Williams talk about how she does not describe herself as African-American in medical contexts for exactly these kinds of reasons. Can you, will you say something about this?
Sure. I mean, that's a really good question. I think we'll get to it, but you know what? Maybe I should go to. Well, first of all, let me answer your question simply. It would typically be one of two things, and we had no control over it. Either the doctor just said, "Oh, this person's Black, African American," or the person self-identified as Black. Either of those two. But you can imagine a misclassification by the doctor. And you can imagine two individuals who are the same individual, but one chooses to say, "I am African American," another who does not. And it's a quite deep issue. And so for that reason, let's see if I can go to, jump ahead to this slide. So this is a study that we published, I think, in 2007, along with my colleague, my colleague Gary Gibbons, who is now director of the National Heart, Lung, Blood Institute, himself a Harvard Medical School graduate, but I met him actually when he was heading the Cardiovascular Institute at Morehouse School of Medicine, where I have quite a few studies and collaborations. And what we see here is based on literally a handful of SNPs. So now I have to stop myself. The genome, every human genome, has on the order of 3 billion base pairs. And for historical reasons, we distinguish variants, which are common, which are above 5%, which we can measure using these so-called SNP chips that were the most cost-effective way of looking at genomes. So they're variants spaced regularly, more or less regularly across the genome of human genome. And there's about 1 million of them that are measured and that have frequency greater than 5%. And nowadays, the costs of whole genomes is getting so low that it's approaching those SNP chips. But nonetheless, we were able to show the following, that just using on the order of 50 randomly picked SNPs, randomly picked common variants, you could actually identify subgroups of individuals in the following way. But it's important to fully understand this. So this is essentially a principal component view, looking at the first two principal components of variants of several populations. One is the 1,000 Genomes Project, which was a project to characterize the genomics of individuals from various representative populations. And the second was a study done out of Harvard looking at individuals in various parts of America, including mostly in Arizona. And so what you see here, at first glance, you say, oh, bunch of triangles. What are the triangles? These are the Yorubans. These are individuals from Africa. They seem to be clustered together. And by the way, you can do this repeatedly for any 50 random SNPs. Keep getting this cluster. And what is this cluster over here of black dots? These are individuals from China and from Japan, which I can tell you, so those are old enough like me to have been sort of aware of the Genome Project during that time, made the Chinese very uncomfortable because they thought themselves very different than, in terms of origin. Japanese. And here, what you see are individuals from Europe. But this is actually not quite what it's showing. What's showing is here are individuals from the Yorubas. And here are individuals who identify as African in the United States. And what you see is some of them seem to be closer to those who have European ancestry, and some are closer to the Yorubas. And the open squares here are the Americans who are coming from Europe. But there's important things to note. And as Gary repeatedly points out, you have to understand that although these individuals likely have mixed lineage due to rape or hopefully, but unfortunately, unlikely, less benign causes, in addition to multi-ethnicity here, he points out, he says, Zach, it's amazing that we're measuring this African population by this one group of Yorubas. Because in fact, Africa is a big continent, and in fact has more diversity than all European and Asian populations put together for good historical reasons, which is humanity came out of Africa, and only a small group in successive waves came out and populated Europe and Asia. So that small group was a tiny subset. These are hundreds of families, as opposed to the massive amount of heterogeneity in genetics that remained in Africa. And what Gary likes to point out, he says, Zach, because I would trade some Jewish history from him and he'd give me back some African history. He says, the port at which you appeared in the United States as a slave was highly determined by where in Africa you got picked up. So different ports basically specialized in different routes. And so there was actually quite a bit of heterogeneity in where these Africans were coming from. Not that they had any choice about it. And so a lot of this diversity is in fact the diversity of Africa, which is actually much greater than is being shown here. But I want to make another point. This is just a dimension of genomics. The fact is that the dietary habits of an African American living in Mississippi is much closer to the dietary habits of a white person in Mississippi than it is to someone living in Nigeria. And that has huge consequences on health. Our American diet has many good properties, but also has many noxious properties, not least of which is causing the whole diabetes, heart disease pandemic that is now actually taking lives away from life expectancy in the United States across the board. And so just looking at someone's genetics and saying, hey, you're closer to the Yorubans, if that's the only way you're looking, we're actually missing things like diet, medications, exposures like allergies that are quite different than what you see in Africa. And one of the dangers we've had is that there's been, because genomics has been so successful in just categorizing the sources of variation. The temptation for genetic reductionism, and I'm talking about apart from truly racist uses of genetics, but the temptation just to go to genetics reductionism is huge. When I talked to the director of NIH, I said, we've been very successful with the human genome project. What we now need is a human environmental project to measure all our exposures. I said, Zach, nice thought, but what are we going to measure? The genome is finite. The environment is infinite. Now, I think that's actually not an adequate answer, because I think there are some things that we could sensibly focus on. But nonetheless, it explains why people keep coming back to diagrams like this. And so even though content of origin can actually be, content of origin can in fact be noted in part through genetics, the fact is its relevance to human health, it can be quite small. And how do we know this? This is a notion of heritability. Heritability is how much variance in any phenotype, diabetes, is dependent on genetics. So some diseases like Lou Gehrig's disease have very high heritability, but most have low heritability. In fact, the majority of common diseases have less than 50% heritability.
Less than how many?
The majority of common diseases. If you look at most common diseases, from cancer, heart disease, diabetes, is well below 50%. So the majority of the variance is not coming from genetics, although genetics, paradoxically, because of our huge ingenuity, is now the easiest to measure. And so beyond the racist agenda that is around genetics, there's also one of sort of scientific convenience, because you have all of us who are data nerds. By the way, I should let you know that in addition to being trained in medicine, I have a PhD in computer science back from the heyday, the second heyday of AI. That was in the 1980s. And so I did, back then, machine learning, but AI was expert systems. And I have lived through the painful AI winter, where if you wanted respect or funding, you did not use the words artificial intelligence. And so that gives me it's a talk for another day. It gives me a little bit of, well, not full-fledged optimism for all the different ways we say AI is going to be used. But did I answer your question? Sort of.
It's spoken, you have touched on it nicely.
Okay. All right.
Just
So
come back.
we'll come back to it. Was there someone who wanted to make a comment? All right. So if you recall, we were talking about the fact that there was this race adjustment, and correctly I was asked, well, what do you mean by race? And like my PhD thesis advisor, Pete Solovich, every time I tell him something new, he says, it's amazing, how it's difficult to underestimate what happens in medicine. It's always cruder than you think it is. And so self-reported race or self-reported race or a doctor deciding what your race is how this formula is calculated. So Professor Monrai actually then asked, what will happen if we remove that factor, that correction factor that we told you about? So there'll be an increase of 3.5% in chronic kidney disease diagnosis by the 940,000 Black adults who would be diagnosed with kidney disease, which would mean that an increase of 2.1% of Blacks, Black individuals ineligible to donate a kidney. 1.2% would have classification of drug recommendations. An increase of 10,000 referred to nephrologists. I think that's a good thing. Increase of 40,000 were eligible for kidney transplant. So if you look at that, you can see it's arguably a good thing and possibly a fraud thing, because is in fact the change in drugs going to result in the best outcome? Is the treatment for cancer by lowering the drug dose going to create either worse outcomes, or it's going to spare toxicity to these patients? And the answer to that question, frankly, is unknown because of this reason that our colleague here with a nice purple shirt articulated, which is, how does this relate to the actual function of the kidney? And again, I just want to repeat my answer is we don't truly know, because in the end, medicine works, however poorly, on things it can measure. And what it's measuring in terms of the kidney function is GFR as glomerular filtration rate as obtained by pre-op. But is that the only way? And what's great about these students who asked the establishment to remove the label is something happened that would not have happened without the students, which is the enlightened part of the medical establishment said, we're not sure whether or not this is the right thing, but are there ways where we look at the individuals in a precision medicine fashion, where we just don't look at these individuals as Black or not Black, but we look at multiple measurements that we're able to make on these individuals and say, can we come up with a multivariate equation across, and now I want to harken back to my precision medicine metaphor where I was telling you about the multiaxial view. Can we in fact come up with a multiaxial view that actually does allow people to look the same without actually defining what race they belong to, which is an overly simplistic construct. And this is a paper appeared in New England Journal of Medicine where they did exactly just that. And I'll spare you the section of the scattergrabs to just say that just by measuring multiple variables, just not a whole lot, quite feasible without looking at race. You can actually do a great job in standardizing kidney function. All right. Some guy in pink and yeah, the guy next to in maroon shirt. Yeah.
If you go to the previous, you were asking, suggesting the question about whether or not this set of changes is a good thing or a bad thing.
Right.
That seems to me to be the same question as is accurately diagnosing kidney disease a good thing or a bad thing?
Correct.
And
It is. It is.
I guess my question is, isn't that an independent? Doesn't that question apply just as well to not the non-Black population?
It sure does.
Does it help people to diagnose them accurately as having kidney disease?
Okay, I can't hear what guy in purple pink is
Actually, I
saying.
don't understand why that's a good question, because I thought the question was, will these diagnoses be more accurate or not?
Yes.
We don't know it.
Right.
So if goodness or badness of this is the same question as goodness or badness of like, it seems clear that it seems reasonable to assume that accurately diagnosing people is good.
It's
But
good.
I think you were even questioning that.
But there's because there's two different questions. One is accurate measure of kidney function, and then there's accurate measure of outcome. And because of complexity of medicine, they may actually not be collinear. Which relates to Maroon Guy's question. Sorry about that, Maroon Guy. Which is that even if you're not Black, what's the right measure of your kidney function? And I think what these young students did is to actually make us think exactly along those lines. But I realize that despite yes.
Sorry, in your scatter plots, which we're not going to go into, but
Yeah.
so then with these measurements, are you both
You're able.
diagnosing more Black
This
individuals and
makes
diagnosing fewer white individuals, or is it?
It's such a smart audience. And so now by doing this, we actually made the whites look like more like the Blacks. But in doing so, we're changing a lot of whites. Not reported in this paper, but it's actually going to influence kidney eligibility, kidney disease diagnosis for many, many whites as a result. And there's no ground truth here. That's the reality. And in order to do ground truth, you'd have to follow this out all the way to outcomes. Not about to happen.
So you don't have outcome data.
There's a long lecture I can give about how bad medical data is and how crummy the medical establishment is in creating a culture of data sharing. That's why I want to shout out to my colleague Ziad Obermeyer on the West Coast, who's creating the Nightingale database, where Ziad is allowing people to look at these richly annotated databases and do these kinds of analysis. In the interest of time, and I'm pleased that somehow you slowed me down so that I actually filmed an hour. Here is May 2020. And sorry, yeah, May 2020. And it says, this article says in JAMA, what is currently known about these differences in risk and fatality rates of COVID? In Chicago, more than 50% of COVID cases and nearly 70% of COVID-19 cases involve Black individuals, although Blacks make up only 30% of the population. And I called up my friend Gary Gibbons, who was then at the National Heart Rhythm Institute. I said, Gary, are they really at higher risk? Shouldn't we know this? He said, we don't know for sure. And so, what's the problem? Electronic health records. They sometimes have labels, African American, Hispanic, non-Hispanic. Where are those coming from? Mostly self-reports, sometimes just a clerk looking at you. And there's also sensitivities for release. For instance, I run an international consortium looking at COVID, and I wanted to understand what are the risks for African Americans, for individuals of African origin. And guess what? The French don't even include race in their electronic health records because they're ideologically committed to being race blind. But one of the most active computer scientists I know in the area of fairness and race, Marjane Gassemi, who's now at MIT, formerly of the Vector Institute, was like saying, Zach, where can I get the race labels on these individuals? And it struck me as an interesting moment because Marja has been very vocal about not using these monolithic unitary variables. But now in the middle of a crisis, it may be monolithic, but it does describe a group of individuals very, very roughly, very, very coarsely that are at risk. And if we don't include those labels, we have very little ways to be able to tell you if you're African American, are you at higher risk? That's a very practical problem. And it brought to me the challenge that we have not yet addressed of how to include those labels. And the fact is, I put the concerns regarding accuracy, which we've already touched upon. So 2 years later, and 1 million deaths later, so it's 2 years later, very good abstract looking at do increased cardiovascular comorbidities explain excess COVID-19 morbidity and mortality? In other words, does the mere fact of being poor, of being obese, of having cardiac risk factors increase your likelihood of dying from COVID if you have African ancestry? And the answer is they do not. And they actually don't know what are the causes. So in sort of classical I don't know fashion, they say needs further study. And so this is the real challenge that we have here, because there are, in the precision medicine framework, there are individuals at risk, individuals who deserve getting good predictions, individuals who deserve getting customized treatments. And until we can figure out what is the right grouping, we're going to keep on doing this dance of a multiaxial versus a monolithic, coarse, and often incorrect grouping. Someone point out that there are other groups who have similar risks. This is a history of the Jews in Europe. And what you see here is the estimated time using coalescence modeling, where various rare diseases popped out in Jewish history. Why? Because a town would be attacked by a bunch of Cossacks. Everybody would be killed except a few individuals. And those would become the founders of a population, because then they'd have a lot of children, and then it would expand out. And so many diseases that are rare in the general population are very, very frequent in Jewish populations. It's actually pretty daunting. So much so that, for example, we have high incidence of BRCA2 mutations, and a lot of Jewish women are not, and now men are not too happy about this association, because, at the very least, although you can't, because of GINA, you can't discriminate in health insurance, but you can still discriminate in life insurance. And so just knowing that you're Ashkenazi Jewish puts you at risk. And some diseases, for example, like see, familial dysautonomia. Basically, we don't know of any non-Ashkenazi Jews who actually have that disease. So basically, being Ashkenazi Jewish is a condition for making that diagnosis. And so there's more to being Jewish than our genetics, but at the same time, knowing in a multi-axial way what our risk factors are has been a very active part of our consciousness, which is related for cause, for example, diseases like Tay-Sachs to drop down by an order of magnitude. So questions for us all to wrap up. Under what circumstances is reductionism of ethnic or race label justified? Does a health outcomes, do health outcomes can show differential health outcomes? Is that sufficient to use those race labels? Is an acceptable answer to use these temporarily until we can come up with a more richly multidimensional label? Or should we never do it because of the moral hazard? Who decides? Is it patients? Is it insurers? Is it the government? Is it computer scientists? Who decides this? And how do we actually shatter? What's the fastest way to shattering monolithic group labels? Should we actually be capturing environmental exposures to get away from genetic reductionism in a more systematic fashion? The CDC has this amazing set of studies called the NHANES study, which every couple of years they drop down trailers all over the United States in locations actually designed to be representative of the United States, and they measure thousands of variables on patients, on U.S. citizens, actually just U.S. residents. So do we need larger such studies? And a very important point is the following, which is we did a study where we asked a question that had been asked of Harvard Medical School students and doctors 35 years ago, and we repeated that study 30 years later. We're basically asking them if a test is 100% sensitive and only 95% specific, which is really high specificity for a disease that's 1 in 1,000. If I tell you that your test is positive, what's your probability of having that disease? And the short answer is 2%. And as you can see, about half the group gave the correct answer, and half the group gave an incredibly incorrect answer. And this was the same distribution as seen. We published this in an article called Medicine's Uncomfortable Relationship with Math. But this is literally the same question that was asked 35 years earlier with the exact same results. And so my last question to you is, how are we going to teach prognosis conditioned on multifactorial conditions, given the crazy innumeracy of the medical establishment, that even though we require calculus to get into medical school, most medical students try to forget it as fast as possible by the time they're, and of course, probability theory is not a requirement. And that's actually where I believe machine learning plays its most important role, is that's the vehicle that's going to carry water. And this is both the opportunity and the danger. It's the opportunity because of the innumeracy of clinicians. If we're going to have multifactorial diagnoses, prognoses, therapeutic decisions made, it's going to be through machine learning. It's a danger because now we've disintermediated humans in a large part. And so if these algorithms don't have the right oversight, don't have the right social values baked into them, then essentially our patients will be relatively naked with regard to the recommendations. With that, I'll stop and thank you.